Covid-19, when it hit landfall back in 2019-2020, I was one of the frontline volunteer doctors to work in our isolation center in National Hospital, Abuja. And so when the vaccine eventually came to the country, I was privileged to be the first Nigerian to receive it during the public launch here in National Hospital, Abuja. I was the guinea pig, so to say. My name is Dr. Ngong Cyprian Margaretson. I'm a family physician, a fellow of the West African College of Physicians. Routine health checks are tests and physical examination history taken on people who are ostensibly well. It's not like they really had a symptom, what we call asymptomatic, and they just come to hospital to have those checks. The idea is that sometimes people may have some ailment, but they are not really sick, and you get to detect them even before they become symptomatic. That way you could treat that disease early enough, and it might be curative as opposed to it being fatal. Yes, that's a tricky question because in some contexts they might not be that necessary. But with family medicine, where your primary care provider is well versed in those tests, and he would look at who the patient, they are individualized, so there's not a one jacket fit all. So for some people they might not be necessary because the context is which tests are you going to do and for who. So you may see people advertising all sorts of tests, executive tests. You see a package with all sorts of tests there. Some of them are not really necessary. So the answer is actually yes and no, depending on the patient that is coming to you, or the client rather, because most of the time they are quite healthy. That's why we said it is not always necessary. There might be drawbacks. In the West African sub-region where we are now, the patient-to-doctor ratio is already so high, and it means that the physician is busy taking care of people who are really sick. Now somebody comes who is quite okay but wants to do a lot of tests. The likelihood is that those tests, they are not infallible. Sometimes you have what we call false positive. A test will say it's positive and actually the disease is not there. And you are basing everything on the machines, so you now order for more extensive tests. And so that concept sometimes causes overdiagnosis, overtreatment, and sometimes you now proceed to more invasive tests that might not have been necessary. And that is why when it is done by a family physician who will also take your history, he knows the risks that are involved in those tests. So if it is done in the proper context, the drawbacks will be limited. But if you now just go doing tests like most people will request, you may find out that you will be over-treating the patient, you will be over-diagnosing, and sometimes some diseases, like we say, people die with them, not from them. So I give an instance with prostate cancer. If you take people who you go to the mortuary and do like an autopsy, you will find a lot of people with prostate cancer that never manifested in their lifetime. So if you had done a test to detect them, you would have actually overtreated, done some tests, spent some money that was not really necessary. So the context matters a lot. The types, actually, we can just say they depend on the gender, the age of the patient, and then why they are presenting. For women, of course, depending on the age too, some of the checks that can be done in them include screening for cervical cancer. This is very important because if it's detected early, when it's still pre-cancerous, there are procedures that can be undertaken to prevent it from progressing to an invasive cancer. Of course, you have breast cancer also in women. And the screening modalities might include doing things like the mammogram for those above 40 years. But usually routine screening may start at age 50 and be done every 3 years. Of course, you screen for other things as usual, the blood pressure, especially if they have such a history. Anytime somebody comes to the hospital, you will always want to check their blood pressure. Ovarian cancer is another cancer you find in women. And then, of course, screening for things like sexually transmitted infections, depending on the history too. Another thing we tend to forget is intimate partner violence, things like depression. Some of these are just screened by taking history, not necessarily doing a test, but we must not forget them too during periodic health checks. Men too, we start with things like the blood pressure. Of course, for men, you're thinking of the prostatic cancer. Screening would depend. Sometimes we do some tests called the prostatic specific antigen. The values we get might tell us if we should go further with other invasive tests. Generally when you look at the tests you're doing, you have to make sure it's safe, it's also available, and it can dictate a latent phase for you, such that if you were to treat at that stage, it will offer a better prognosis. Things like diabetes, hypertension, dyslipidemia are so common with us. Non-communicable diseases are taking over in terms of how much death and mortalities they cause. And things like hypertension is simple. Just taking the blood pressure alone can screen for hypertension, and it's sequela. We know that we are trying to prevent something in the end. Things like stroke, heart attacks, chronic kidney disease, just a simple screening of the blood pressure. And this can be done at every office visit, especially when somebody has a history of hypertension. For dyslipidemias, you can do a screening, usually from age, say, 22, one single screening, and then maybe every 5 years or so, depending on how the patient is. Sometimes we look at other things like if they are obese, they have other diseases. If somebody is diabetic, of course, the cholesterol is likely going to be high too. And then diabetes too, with the family history, with whether the person is also obese. We measure the weight and height during all the screening. We can also screen for those, and they are simple tests that are not so invasive. Well, ignorance in this for health is not bliss. I think it's more of like an abyss. It's more like a deep place you can just go and fall into. Ignorance should not be allowed in healthcare. I give you an example of HIV. There are cases of HIV where even the market woman will look at you and say, this person he has HIV. But at a point when you felt the symptoms, or if you just had a check and they did the test, and the treatment started, you will never even have any symptom. So sometimes we feel ignorance is bliss, but it's actually an abyss that you can just fall into. So my advice is that every patient should have his family doctor, should have a family physician whom he sees regularly. This doctor is well versed with the art of general checkup. They would take their time to know which tests are good for them at that particular moment in time. And it's a continuous process. So people should get their family physician. COVID-19, when it hit landfall back in 2019, 2020, I was one of the frontline volunteer doctors to work in our isolation center in National Hospital, Abuja. And it was, I would say, most people would think we don't have fears, but my fears was not personal fears. I felt it was like the end, and now people have to be deployed to be in the front line. And whether we go there, it will come and meet us at home. Whether we volunteer and go there, our families are there, and it wasn't something that you could say you could block somewhere. So we are at the forefront. As at then, the drug treatments were not as We didn't have much knowledge based on them. All we could do, we know that when we gave some oxygen, the oxygen saturation would go up. Of course, back then, chloroquine and other drugs that we're using without real evidence base. But we found out that most of the people that were affected by COVID died from, say, fear or mismanagement of other comorbid conditions like diabetes and hypertension. And we found that the little we could do to control the blood sugar and blood pressure and all that helped a lot of people to survive. And so it was really a good asset. Then the vaccines were not available. I had colleagues who had taken the vaccine in the UK, and I kept telling them, how do I get one? Do I have to travel out there? Then everywhere was locked down. And so when the vaccine eventually came to the country, I was privileged to be the first Nigerian to receive it during the public launch here in National Hospital, Abuja. I was the guinea pig, so to say. And I received it willingly, and so far it's been good. We thank God because we expected, like some people had said, for corpses to litter our streets. But somehow the situation is well contained, even with the poor infrastructure. Yeah.